I'd like to thank the chair again for getting us on time. I want to remind everyone who has been invited to the GSK Luncheon Symposium that you're expected to be over at the Aberdeen room at this time. We're going to get into what I call the favorite part of the whole meeting, and that is the various awards. The first award the first number of awards we're going to talk about are the best in the leukemia category, the best in the hematology category, and the best in the lymphoma myeloma category. And I would like for Dr. Chim to come up and announce the winners. If Dr. Chim, if you would. The certificates will be given to the award winners at the registration desk. Dr. Chim there, these three.
Okay, so I think this is a great time to announce the award winners for the Best Poster Award. So the first one is the Best in Leukemia category. This belongs to Dr. Chi Long Chang. Okay. So the title of his study is High Bone Marrow LGALS3 Overexpression is an independent unfavorable prognostic factor for overall survival in patients with acute myeloid leukemia. So Dr. Chang, please. Okay, so maybe Dr. Chang is not around. So I would like to announce the so Professor Tin, please. Oh, certainly.
So please come forward because we're going to take your picture in just a moment. You mentioned the second one.
Okay.
Say congratulations.
So the second award winner is the Best in Hematology category, and the award goes to Dr. Prashant Sharma, whose poster is focused on incorporation of FLAIR in a flow cytometric panel for PNH in patients with aplastic anemia, enhances detection rates and reduces ambiguous results. Dr. Sharma. And the last and the third poster, the Best in Lymphoma and Myeloma category, belongs to Richter Yim. Epigenetic inactivation of MIA-1292 in hematological malignancies. Richter, come forward, please. Thank you.
Thank you very much.
Thank you.
Thank you. We are now going to announce the recipient of the Preceptor Award, and this award, that comes later, and this award is for a preceptorship award will give this particular individual 6 weeks rotation at MD Anderson Hospital. And I'd like for Dr. Huang, if he's here, to please come up and present and announce the winner of this the recipient of this award. This is the recipient, and that's his university, this gentleman. And if he can come up and give him the certificate. And here's the certificate.
This is Hong Ping.
That's his, right, and this is where he's located.
Okay.
And here's the certificate.
So the winner of the preceptorship is Hong Bing, Sichuan University Western China Hospital. Please, Hong Bing, Sichuan.
Is the recipient here? Would he please come forward?
Yeah, sure.
Are you going to represent him?
Yeah. I think he's the director of the Sichuan University. Okay.
And finally, we're going to ask Dr. Champlin if he would present the award to the best overall poster abstract he will announce the award winner, and we will hear a 10-minute presentation from the award winner. Dr. Champlin.
Okay, the best abstract award is given to Han Hu Zhu, and the abstract title is Oral Realgar Indigo Naturalis Formula achieved comparably high rate of remission and survival to intravenous arsenic trioxide as frontline treatment in newly diagnosed acute promonocytic leukemia, a multicenter randomized trial, APL07. For Hong. So, congratulations. You have a certificate. Let's see if okay. Congratulations. He also gets $1,000.
Good afternoon, everyone. Very glad to have the chance to give the presentation here. The topic is oral arsenic tetrasulfide formula achieved similar efficacy and safety compared to intravenous arsenic trioxide as a first-line treatment of APL. I first introduce the background of the trial. As you know, the arsenic plays a key role in cure of the APL. From this slide, we can see ACHA and the chemotherapy and arsenic can achieve about 90% patients long-term survival. There are two kinds of the arsenics available in clinical settings. One is intravenous arsenic. It's very effective, but it must be infused intravenous. It's very inconvenient for patients. Another kind of the arsenic is oral arsenic. We have demonstrated its effectiveness about 10 years ago and published in Blood. And this drug is very convenient. But until now, no randomized control trial to answer whether all the oral arsenic have similar efficacy and safety with intravenous arsenic in treating APL. Therefore, the purpose of the study is to demonstrate that oral arsenic can be used in place of the arsenic trioxide as a first-line treatment of newly diagnosed APL in a multi-center randomized control trial. Therefore, Chinese APL cooperative group, including 7 centers, initiated this trial from 2007 to 2011. The median follow-up time is 32 months. The two groups in our study, the control groups used the intravenous arsenic trioxide, ATO, and the trial groups we use oral arsenic tetrasulfide formula. We named it RIF. We include the patients with de novo APLs and age is between 15 and 60 years old. The important we include the patients owning WBC below 15 and also had adequate hepatic and renal function and good performance. This is our trial design. All the new diagnosed APL was randomized to receive the oral arsenic or intravenous ATO, and all the patients also received the ACHA during induction therapy. After achieving complete remission, all the patients received the same chemotherapy, and 3 cycles consolidation chemotherapy, HA, MA, and DI regimen, and then received the maintenance therapy with ACHA and arsenic in a 2 weeks on and 2 weeks off model. These are detailed drugs and the doses during the induction therapy. This slide shows the consolidation therapy, include the HA, MA, and DA regimen. Maintenance therapy include the arsenics and the ARCHA, use the same doses as the induction therapy. The primary endpoint of our study is disease-free survival, and the second endpoint is complete remission, over survival, and safety. This is our chart profiling. Totally 242 patients were involved. And we can see first, until to last full time, 111 patients live in complete remission in oral arsenic group, and 113 patients lived in CR1 in the intravenous arsenic group. This table shows the baseline of the two groups. We can see there is no significant difference between baseline and group according to age, gender, WBC, and the platelet, and the sense score, and the blast percentage in the bone marrow. We can see the similar outcome of the two groups according to complete remission, DFS, and OS. This slide shows the similar disease-free survival between two groups. About 19% of patients achieved 3 years DFS in the oral arsenic groups. A similar result was also seen in the oversurvival. We also detect the molecular kinetics. We can say all the patients have achieved molecular remission after 3 cycles consolidation chemotherapy. We also concerned about the liver toxicity. As we see, during induction, use the ARCHA and the arsenic combination, the liver toxicity is very common. There's no difference between two groups, but the 3 to 4 grade liver toxicity is low. However, during the maintenance, we use arsenics alone, not the combined ARCHA. Therefore, there 3 to 4 grades liver toxicity is very low. We also find the similar rate of differentiation syndromes between two groups. From the result, we can draw a conclusion: oral arsenic achieved similar efficacy and safety when compared to intravenous arsenic trioxide. Our results also suggest that arsenics, ARCHA, and chemotherapy combination might be an alternative to current frontline treatment of the APL. We also thank all the doctors, nurses, and patients involved in our trial, and thank you for your attention.
The speaker can take 1 or 2 questions if there are any for him. Please.
Thanks for your very excellent speaking. I come from China, Anhui Provincial Hospital. I have 2 questions. One is, do you give the patient induction treatment according to the risk group? Did you, according to the white blood cell and platelet count, put the patient into different groups, low risk, standard risk, or intermediate risk, or high risk? The second question is, did you give the patient consolidation and maintenance treatment according to the level of the PML level? Thank you.
Okay, a very good question. The first question, we didn't give the treatment individuals according to the census score, the low risk or high risk. We include the patients below the WDC below the 15, and include some patients of high risk. All the patients receive the same treatment during the induction therapy. And the second question, we detect the molecular, and we don't treatment patients during the molecular turn to the positive. So the patients, only 2 patients relapse during the follow-up. Thank you.
Thank you, Dr. Thank you, Dr. Zhu. We have one more announcement for one more best all-around poster, and that goes to the author of Zhuan Yang. Dr. Yang, are you here? The poster was the coordinated regulation of the immunoprotein subunits of PML-RAR alpha and PUI in acute promyelocytic leukemia. Dr. Yang, if you're not here, we'll be sure that you get your presentation. This is really the, since the simultaneous sessions will be occurring this afternoon, this is the last moment I have to express my sincere thanks to Dr. Simrit Palmer, who has done absolute yeoman's work on this conference, as she does every year. And also to express my thanks to all of the speakers for exciting and illuminating and very informative talks, and to you, the audience, for attending. We'll see you next year in Taiwan. Lunch is being served next door. Thank you.